Well, okay. Thank you. Good morning, everybody, and welcome to this meeting of Herefordshire and Worcestershire Health and Care NHS Trust Board. We've got a very long agenda today because there are some important matters that need discussion. But before that, I'd like to welcome Sue to, I think, is your first meeting of the board today, because you had planned annual leave for the meeting in May. So you're very welcome to your first meeting, and your contribution will be very welcome. I know that we've got a 2 or 3 guests that are joining us for the patient story today, and Natalie will introduce you when we get there. At the conclusion of the patient story, you're very welcome to stay with us, but I do understand if you've obviously got other business as well. We have one apology today. I think that's only Lisa, but also there is this meeting marks a little bit of a watershed as well, because I think it's traditional to say goodbyes at the end, but I'm going to do it at the beginning, really. And Steve Peake. Steve, and I think I don't know what it is, but you're right in the middle of my screen, Steve, on here. Steve is due to retire from the trust at the end of this month. So where are we now? 20th, 10, 11 days away. He's due to retire after around 9 years as a non-executive director with us. For a long period of that time as deputy chair, and certainly the deputy chair to me for my first 2 years in the trust, and looking after our finance and performance committee for, I think, almost all of that time, but certainly a long period of that time, a majority of that time. And so, to Steve's embarrassment, I'm going to say a few words. And the reason I'm saying a few words is because Steve's had a significant influence across all areas of the trust. Yes, he's focused on F&P and been deputy chair to both myself and my predecessor. But his influence has been quite wide, I believe. And the thing that has always impressed me about Steve is that he embodies what I think an NHS non-executive director should be. When appropriate, there's no issues with Steve giving constructive challenge, but it's always done in the right way, in a constructive way, to assist discussions or assist getting to the assurance or the point we need to. And other times, support and empathy is also there. But those two things are the bits that get written down, if you like, as to what a non-executive director should be. And Steve certainly embodies that. But what he also brings is that interest and motivation. There's not a subject that we discuss in the last 2.5 years that I've been with the trust where Steve doesn't show a high degree of interest and on occasions empathy with the issue that's being discussed. And I think that's really crucial for a non-executive director. And linked to that is obvious high levels of motivation to do everything that's possible to improve the lot for our patients and our staff. And that's, I think, encapsulates exactly what a non-executive director should do. So, Steve, we've got a couple of able replacements for you in that Janet stepped up to the mark for to be deputy chair, and Biraj is going to step into the breach for the F&P. So we're really delighted that we've got able replacements, but that doesn't detract from the fact that we will miss you, Steve. Your knowledge and wisdom will be missed across the board. So thank you for your service and thank you for your commitment to the trust. But if I may personalise it a little bit, because that's to the trust, but to me personally, from the moment I joined the trust, as you know, could be viewed as a bit of an outsider coming from that acute trust, Steve welcomed me as the deputy chair with open arms and provided advice and guidance to me whenever asked. He was always there and always very, very welcoming to myself personally. And I've certainly welcomed our personal relationship, Steve, and have become certainly very quickly came to trust your judgment, trust your advice and trust your views. So on a personal level, I will personally miss that, albeit that others will step into the breach. I, on behalf of the board, wish you well for whatever you do in the future. And I know you've got a number of changes in your life at home, which are all very exciting. But we certainly wish you well, and we wish you all the best health and happiness for when you step away from the trust at the end of this month, Steve. So thank you very much indeed.
I will just save my embarrassment and just say it's been an absolute privilege, and I thank you for all those kind words. But we've got much to talk about this morning, so we should crack on with that, I think. But thank you.
Absolutely correct, and I expect full contribution from you, Steve. There's no slacking right up to the last moment.
No. We have a meeting next week that I'll be there for as well.
Indeed.
So yeah, thank you.
Okay,
thank you very much.
As Steve says, we'll move on to the minutes of the meeting held on the 18th of May. I don't intend to go through them page by page, but does anybody have any matters of accuracy or clarification? Tessa?
Yeah, it's just a minor clarification, Mark. On page 13 of the minutes, page 19 on diligent, it says that Miss Norris explained the committee also invites the associate hospital managers to the meeting. That is true, but actually what I was trying to reflect is that it's an unusual committee in that all of the associate hospital managers are core members of the committee. So they're not invited as a sort of one-off, but they are core members of the committee. And I think that just needs to be reflected in that sentence on that page.
Okay, so I'm sure that that minute can be amended, and if Sharon / Jill could do that and perhaps just run it by you to check that what the amendment says is what you intended, that'd be great. Thank you very much.
Brilliant.
Anybody else? I did have one, and it was just somewhere in the minute, which I know isn't particularly useful, but it's not a clarification. It's a question. We mentioned the excessive waiting list for adult ADHD diagnosis. And I know it was raised at ICB that I was at yesterday, and indeed it even featured in the Health Service Journal this week as well. But in the minute, it references that we were undergoing discussions with the ICB about whether there's anything that can be done. Can anybody illuminate the meeting on how those discussions are going, or if indeed if they've started at all yet?
Matthew can update, I'm sure. Mark.
Thank you, Sarah. Matthew?
Thank you, Chair. Yes, so I guess three main points. Firstly, John has secured the services of a consultant psychiatrist to replace the hours that have been lost by the current psychiatrist retiring at the end of June. So we've got some continuity of service. Second of all, an ICB group, task and finish group, has been formed to look at designing and creating a more sustainable model for the delivery of ADHD services for adults. Thirdly, we've expressed our intention and agreed with the ICB that as a provider, due to high levels of demand and our inability to meet that level of demand with the current model, that we will be giving 12 months notice on the provision of the service. So we will run the service to specification, to the current specification, until the end of July 2024.
Thank you, Matthew. Jamie, did you have a question there?
Mark, it was only to say that to me, and I think to several other people on the meeting, your image is frozen. I don't know why. We can see you and hear you, but it's a static, frozen image of your face.
On some of us, I think we've got a black screen for Mark, no image at all.
Oh, I'm at a loss as to how to cure that at all. Maybe a blank screen is telling the world something. Just for a second then, because that's not particularly useful. Let me just take 1 minute of your time to come in and come out again. 1 second.
That's better, Mark. We can see you again now.
Okay, hopefully that cures it. If it doesn't, I do apologise. I'm no great IT technician, so I wouldn't know what to do to cure anything. Okay, thank you, Jamie. Thank you for raising that. If there's nothing else on the minutes, again, thank you to Sharon, Jill for doing those. An excellent set of records for the meeting that we had. And we can accept those. If we can move on to the action log, although both actions are complete, is there anything to add or any questions on those actions at all? No. Okay, if we can note those. I've not been notified of any questions from members of the public. and our declarations of interest are on the website. And just a reminder to all that if any of your declaration of interest change, please inform Jill, who will then amend the website and record them accordingly. Right, we move on to the main crux of the agenda now. I'd request everybody today, we've got a long agenda and we have put timings against each item, which are, it would be great to stick to them, but the business will dictate that. But I would ask all contributors to be mindful, if I could just add it in that way. If we move now to item number 8 then, which is patient story, slightly different this month for good reason, and I'll hand over to Natalie, who will explain. Natalie.
Thanks, Mark. Morning, everybody. Yes, our patient story today, we're joined by a number of our colleagues from the Starting Well Partnership, so I'll hand over to those in a moment to describe the service. Normally, we would see and hear from the patient directly. The trust board members have all got a full video of Louise and I and Nikki spending time with our patient and listening to her experiences. To protect the confidentiality, we don't feel that's appropriate to share in the full public domain, but we've gained from that full story, which is fantastic. And what we have is we have a summary of what her feedback is. So I'm going to hand over to Louise first, and then I'll go through Charlotte's story. So thank you, Starting Well team, for being with us today.
Thank you. I have a short presentation to share a little bit about the background to the project that our mother talked about on the video. So it's just a little bit about the background to Starting Well as well as the project. So as you know, the Starting Well Partnership is led by the Trust, and our partners are Barnardo's, Redditch Council and Action for Children. And we, public health nurses, which are the health visitors, deliver the Healthy Child programme, which are assessments at the antenatal period, the new birth period, a 10 to 12 month development review, and a 2.5 year development review as well. So following those assessments, we work as a partnership to deliver what that family needs, and that can be about development. It could be some of our community workers providing groups in the community for those parents. It could be parenting groups. A variety of support is offered by the partnership, and we can signpost those parents and hold those parents to those sessions as well. For our peer support project, due to the increased pressure on services for children and families during the pandemic, the services were given additional funding via COVID recovery from public health, so our commissioners. We know that to build more resilient, empowered communities, we need to support communities to find their own solutions, which was the theme of the peer support project. So the service models involving peer support and volunteers can be real powerful tools to identify and strengthen community assets, community capacity and sustainability, and provide a crucial layer of support between communities and local professionals, such as our health visitors. So the additional funding was used to implement a peer-to-peer support for families called Start for Life. The project itself, the aim was to develop a network of support for those communities through recruiting and training individuals with lived experience to then support their own communities from conception to age 2. Because we know that research shows that the first 1,001 days of a child's life is a window of opportunity to create great outcomes for that child. So a series of informal but focused one-to-one home visits is the core feature of the service delivery through informal support in a parent's home, but they can also meet in community settings as well. A continuum of reliable, regular and consistent support is delivered through a trusting parent-to-parent relationship. So the aims of the project is to assist pregnant mothers and their partners to confidently prepare for birth and becoming parents. Encourage and enable parents to build their own local support networks. Encourage sustained breastfeeding, smoke-free homes, and warm and confident parenting. Provide personal support to help parents navigate the maternity and other service and communicate effectively with professionals. Support the best start in life for the babies and children of vulnerable parents during the first 1,001 days. And increase resilience of parents and communities to support them to become less dependent on limited professional resources. So how it actually works, the additional funding, volunteer coordinators were employed. They engaged new Start for Life peer supporters and ensured that they were all trained and inducted to a high standard. Ongoing support is also provided to those peer supporters, so constant supervision to ensure constant recruitment and retention is factored into the project as well. Health visitor and midwives highlight families that would benefit from the peer support programme, and then the coordinator role oversees the incoming referrals for expectant parents and allocate the Start for Life peer supporters accordingly. As to date, we have around 20 peer supporters. Is it working? Well, we're hearing that lots of powerful stories from parents, which you will have seen one of them on the video, that are currently receiving Start for Life peer support. The benefits that we've seen so far are parents building their confidence, they're feeling more supported, they're preparing for the changes ahead, and they say that they feel less stressed. Improved well-being of parents obviously means a healthier pregnancy, less complicated births and happier babies. And parents get to know what services are available to them as well, services that they may never have come across before, and our volunteers help them to benefit from them. So the benefits for the peer supporters themselves, they get a satisfaction. They're telling us from giving back to their community. They make new friends, improve their confidence, and they're also developing new skills and gaining different pathways to employment themselves as well. And a wealth of evidence shows that volunteers can gain satisfaction from contributing to the well-being of others, increased awareness of the local community issues and available services, and increased self-confidence, self-esteem and a sense of achievement, which we're definitely seeing with our peer supporters. So the future of the project, the funding is available until March 2024, and there is no further funding available. Obviously, early evidence shows that it is working. It started in January, so still really early days, but we're having such successful results to date. So we're looking at how the service can incorporate this into our normal service, and that may mean losing some of our other volunteer opportunities to really embed this way of working without the funding coming through from next year. And we're discussing with our commissioners on how this can happen as well. And that was Whistle Stop Tour.
Thanks, Louise. You shared so smoothly. You're now going to show me up as well with my inability to share my screen effectively. Okay, so can everyone see that? I can only see Louise. If somebody could just give me a yes or a no, that'd be marvellous. Yeah, perfect. Okay, so and Nikki, I know you're with us, so please feel free to contribute. Obviously, no mum well. Just to summarise, so we met with Mum on Monday, and she went through her story with us, which was really powerful. So at the age of 40, she had a surprise pregnancy. It was a happy event. She'd wanted to be a mum, so it was a happy surprise. But that then led to a breakup with her partner, which she described as being really quite tricky and difficult. She's a very successful woman in a professional job, lots of responsibility, clearly holding down her job well and succeeding at her job. And her job was really obviously very important to her. And she described a great structure to her life and some previous mental health challenges that she was also had overcome and was still working with. She clearly felt very driven to make sure that everything was in order before she went on her maternity leave and really worked successfully up until that due date. She had a few challenges in her pregnancy. As I said, previous mental health conditions were still lurking in the background and providing her some challenges, but worked really well through those. She then described the birth of her daughter, which was a joy. She's a lovely little girl now, but hadn't really prepared for the role of being a mum. She was so busy, and then was left with this sense of, well, how can I do it all? How can I make sure I'm a really great mum? The house is really tidy, and how can I stay in that comfort zone? So she was referred to the peer support service after baby was born, and she was really appreciative of the one-to-one support. The peer support workers talked to her about the group support that's available, and she described it. They keep inviting her in, which is great, but she knows it's available. She's just not quite ready yet for that group work. She talked about the benefits of that peer relationship in talking about anything. Pouring her heart out was the expression she used. She really ended up opening up and telling them everything. She felt they were really there for her, and described it very different from a relationship with a professional. So she'd experienced perinatal mental health care. She'd experienced a health visitor, and described those relationships as being incredibly different from the ones she's established with her peer workers. She has consistency, so she sees 2 peer workers and they are available. As I said, they keep inviting her, making sure that she's really well connected. And then making no assumptions either. So she's, as I said, she's a very, very competent professional person. So she might look and sound like she doesn't need help with certain things such as her finances, but actually she did. And they've helped her navigate around a system that she's not as familiar with. And actually through that support, she's able now to extend her maternity leave and not go back to work so soon, which she feels is a really positive thing. They're really flexible, so they she described the peer workers as they're happy to help her practically around the house, or they're happy to look after baby so she can do that, or just give her the time, so looking after baby so she can go and get that shower and that 5 minutes me time, which is really important, enabling her to be a more positive mum. Louise asked a fabulous question about the benefits to the mum and daughter relationship. And what mum described was, as a single mum without a support network, she didn't know what normal was. She didn't know what good was. She didn't know what thriving babies looked like. So it was the peer support work has been brilliant at enabling her to understand she's doing great and she's doing really, really well. The fact they're mums, they've been there, they know what they're talking about, they can relate to her. And she really emphasised this is way out of her comfort zone, being a mum, and the skills needed for that. And she also spoke about the fact she knew they were there whenever she needed them. She had their numbers in her phone and she knew that they'd respond whenever she needed. So thinking about the wider learning points, Mum reflected to us, actually, she thinks she would have benefited from peer support earlier on, such as in her pregnancy when she was under the perinatal services. So how can we make sure that we're connecting people at the appropriate time? She asked a very direct question about why is this funding not going to be available? Why is the service at risk? It's a really good service, it's really invaluable. So why would that be happening? And then for us as an organisation, the strength of the model here around peer working is really evident. So really a thought for us around the evidence base is really good in peer workers. There's much more evidence actually mental health as well. I've attached a paper there for people who might want to do a bit more reading. But are we maximising our peer working opportunities to enable all of our patients and service users to benefit from this model of care? So thank you.
Okay,
Nikki,
thank you.
Nikki, I don't know if you just want to jump in at that moment, if there's anything I missed from Mum.
I think
no, I don't think so, really. I think you've done a really good job. I mean, when we first went to Mum, she was extremely overwhelmed. And I think, as you said, whilst obviously her baby was very, very wanted, I don't think she'd realised the enormity of what it meant to actually have that baby. And so when baby had arrived and then she was left with, she got home and she was back in from hospital, I think she just didn't really know where to start. And she described herself as not having really anybody that she had no friends that had babies. She had no real support around her. And so, you know, I think the fact that we were able to go in and just be that bit of support, and just, I think probably the biggest thing for her was to be able to just give her time and allow her our time. And, you know, we have spent time with her because she's really needed it. But I think she's absolutely flourishing now. She's doing great and her confidence is growing all the time. You know, when we tend to arrive there, sometimes she's, you know, stressed, as most new mums are, and, you know, but by the time we've sort of sat down, we've held the baby for a bit, we've talked things through, she's calmed herself right down, and that's really good to see.
Okay, we've got a range of questions, so I'll kick off Martin first.
Yeah, this is more a question for the board, actually, but I found the video really powerful and really useful, and I just think it exemplifies for us about our responsibility. When we look at the paper we've got later in the board around the joint forward plan, which talks about our focus on the 20%, not the 80%, this is firmly in the 80%, and we have got to be the guardians of maintaining the funding and the flows around that 80% if we're really to achieve this left shift. And the fact that the funding is running out, or we haven't got a plan, so 6-9 months out for something that started in January, I find quite disturbing, and really challenges us about our real commitment to left shift. Rather than having to medicalize everything, we should be looking much more about outcome and impact, not about whether it fits into the definition of health services. If we're really to address inequity and inequality and give people the best start in life. And for me, this story was a sort of wake-up call to say, hang on a minute, these big strategy documents that we've got, which I think is a really well drafted document. How are we as board actually saying yes, but we're protecting the real drive of what we're doing in terms of left shift, not sticking within our confines.
Thanks, Martin. I'll take a range of the questions, and then that one about funding we'll certainly come back to, and whether it's Rob or Sarah or Matthew or somebody will comment on that. But if we take the questions first, and then we'll come back to receive the comments. Thank you, Martin. Janet next.
Yeah, thank you. I would echo what Martin said about the powerful video. I think it really did bring it home. So I've got two questions. One was a bit of an obvious one, which was actually, how much money are we looking at for this? Because I couldn't find that anywhere. And in my head, I think it's probably not very much money at all. So I suppose that was the first one. But I do agree about this, you know, we should be looking at this more widely. But I suppose my other question was around actually, how do we know that the right expectant mums are getting the service? That felt a little bit subjective to me, and I think the fact that the lady on the video said she would have liked to have that earlier made me think that possibly people hadn't realised that she'd benefit until a bit later on. So I suppose it was a bit about the gatekeeping aspect to this, and how do we ensure the right patients or people actually access the service. Thank you.
Thank you, Janet. We'll part that one and come back to it. Tessa?
Yeah, mine's almost a follow-up of what Janet's just asked, because I think it was Louise that said, as a service, we might have to look at some of the other volunteering that we stop in order to allow the peer support to go forward. And I was curious as to what we were stopping and what benefits that had or hadn't had. And the other question was about how many peer support workers we've got doing this service and how many people they can support at any one time. So what their capacity is, and whether we think that what we've got currently matches the actual need, and therefore are we looking to fund like for like going forward, or would we see this as a service that needs to expand?
Thank you, Steve.
It's a follow-up to Martin's comment about the left shift, but it's, you know, we get ourselves into a Western view of the world that actually there is a mainstream service that costs a fortune because it's scraping the burnt toast, and then there is a sort of a community-based, you know, a volunteer-based, a good persons-based service that costs very little by comparison to the consequences of mums and their children not getting this kind of support. I just don't understand why our commissioners can't see that and actually start thinking, what would we have saved in this service had we not had it? And therefore, let's give it a go, because ultimately down the line, this is going to be beneficial to the money and obviously the people involved. So it's how we as an organisation start amassing evidence so that we can put our best foot forward and be champions of this kind of stuff. I think that's got to be, because otherwise the benefits get lost in the morass of patient data and all of that.
Thanks, Steve. And finally, before we move to some responses, Carol.
Thank you. Just one quick question. Can I confirm who the commissioners actually are in this case? It's the first question.
Okay, so we'll pick that. Was there anything else, Carol? Or was that just
and I really just think, I think all the things everybody else has said about left shift, how the system needs to be approaching this, I would say, as having just come out of the voluntary and community sector, what you're seeing here is a snapshot, is what is happening in many organisations across the two counties, waiting for funding ending, and there's some really good stuff going out there. So I'm really pleased that we've acknowledged that, and anything that we can do to try and make that case would be really welcome. Thank you.
Thanks, Carol. Well, in essence, what we've just had asked is, can you advise us on funding and sustainability of funding and how much that funding is and how we're going to maintain a service because of the value of it going forward? I think there's also a part of that, the two other slight bits, which is who's the gatekeeper to make sure that we know the right people are getting the right service? And then linked to the funding, I suspect, is how do we know evidence-wise about the service outcomes going forward, so we can be the advocates and supporters of obtaining the right funding to make sure this all happens into the future. I'm not 100% sure who will be picking that up. Can somebody please advise me, because that cuts across a number of our executive colleagues. Sarah, who will be?
I think Louise has got her hand up, so let Louise come back in first. Sorry. Yeah.
Louise.
Hi, I can talk to you about the funding. So the project we got £350,000 for, and that was the support around it as well. So admin support and some management oversight, as well as the volunteer coordinators and some expenses for the peer supporters themselves. It was COVID recovery funds, so it wasn't recurring funding. It's from Public Health Commissioners, Worcester County Council, Public Health, and they're already obviously seeing really good outcomes from the project and are working with us very closely to refresh our community offer so that going forward, when that income is no longer available, we can incorporate that into our way of working. However, we also do other volunteering support work, such as we recruit volunteers for breastfeeding support, we recruit volunteers for helping our school nurses in schools weigh the children, and there's lots of different opportunities. It might be that we don't put so much effort into those coordinating those volunteer roles because we don't get to see that many outcomes from some of them, but we put our effort into this peer support programme. In regards to the picking the families up earlier, we very quickly learned that actually we need to target our midwifery colleagues. So very, very early on, they can highlight those families. We probably focused in the beginning on health visiting, so perhaps didn't get in there quite as early. But now it was very quickly we learned that we needed to engage the midwives, and that certainly is helping now. Pick those families up early, and that was a bit about promotion and getting out there quite quickly with our midwifery colleagues. I don't know whether Nikki and Amy, my colleagues, wanted to add anything to that.
No, okay. Well, I know Rob wants to come in, and Rob.
Yes, thank you, Chair. It's just a little bit more context, and probably it fills in a little bit about timescales. So this was national funding to all councils, to public health teams. So it was COVID Outbreak Management Fund that was given for recovery of a variety of services afterwards. We worked collectively with the council to come up with a range of interventions that may be helpful. This was one of them. I think in that context, it probably be helpful to understand that this was always one-off monies. There would then have to be a period of understanding, was it successful, and then a period to engage with the council to work out how they prioritise the funding they have in the Public Health Ring Fence grant to potentially continue things if they're successful, or move money around. So, Martin, I think that probably answers a little bit about how the whole process is run. And I think, to be fair to our council, they've been very good working with us on this. So clearly it's early days and we need information and outcomes to evaluate, but those are discussions that are going on.
Rob, could you offer how much a year we're looking at? There was 350 you said was the one-off funding, but did that fund a couple of years, 2 or 3 years, or is that a single year?
I think it depends. That there were actually a number of things we did within the overall conf package we received within the 0 to 19 service. It was over more than 1 year, but Louise would have the detail of exactly what this element is. And I think, you know, there's a bit more work to do. I don't have in front of me, Mark, exactly how much this costs.
The reason I ask, because it would give board an indication of what the yearly, if it is to be sustainable going ahead in the future, what is the yearly ask of finance from commissioners or wherever to maintain this service? Louise, were you able to give us a figure for a yearly?
I think it was 350 for the year. It was an 18-month project by the time it got started and everything. What we are looking at and working with commissioners at the moment is working out, now we know a little bit more about it and it's embedded, how much would it actually cost us now going forward? We might be able to make some savings from what we've learned and things like that. So I can certainly share that with you when we've done some more work on that.
Okay, thank you very much. I think the only thing I didn't hear too much about was our ability to collate the evidence of the outcomes. This plays into the commissioners, doesn't it? You know, if we approach commissioners looking for that funding, then we obviously need robust evidence. Louise, would you be able to comment on the, I suppose, the evidence that could be put on a spreadsheet or a piece of paper, as opposed to that fantastic video we heard of evidence, which is difficult to collate for commissioners' purposes?
Yes, I don't know. Is Amy there? I don't know whether you can help, or Nikki with questionnaires and things that we do with parents.
Yeah, hi there. Yeah, I can come in there. So as part of the support, we complete case studies for the families, and we also complete a pre, mid and post questionnaire. So just capturing the sort of the beginning, middle and end of the piece of support that we do with that family, really looking at sort of self-efficacy and how we're sort of supporting families in terms of developing confidence. So that is something that we could use in terms of quantitative data. I think with anything like this, it's always really difficult because it just comes out in qualitative much more than quantitative. So trying to get that balance. But yes, we certainly have things that we can provide figures for, and that will become more in terms of the more families that we support.
Is that captured? I think that's captured everything that was raised there. from the level of interest shown by board members here, I would suggest we need to hear how this is going, so to speak, and whether the funding is to be replaced in any way, whether there's an alternative method of delivery by reorganisation of resources. Basically, keep us topped up, please. So I would anticipate, if not the next board meeting, the one after that, please. Natalie.
Thanks, Mark, and that's a great idea. And I guess I just wanted to reiterate some of the message here around, Mum shared her details with us and shared that question. We never filter, do we, the patient's story? So we always enable them to express all of their views. So we're right about the funding, but I guess let's just remember that this was a testing pilot project. So that is why nobody's saying that this should not continue after the funding ceased. It was always a set period of time for us to do exactly what we've just described, which is evaluate the impact, go back to commissioners, and look at then what happens after this financial period stops. So everyone's doing an amazing job, and I think that evaluation now is key, isn't it, for us to go back to commissioners and have those conversations.
Yeah, I agree, and I mentioned Steve's wisdom at the beginning of the meeting, and I think what Steve says is really important. We as a board, as an organisation, and I know Natalie and colleagues will do this, but we see the evidence, we work with the evidence, and our teams work with that evidence, and we must be as strong advocates as we can to assist the decision makers to work with us to come up with a sustainable future to a service which so obviously provides some good outcomes. But so if not the next board meeting, then I don't know whom I'm asking. If I park it with you, Natalie, as the person that brought this to us, then if you could bring back updates so we as a board know how that advocacy is going and whether we can make this a sustainable part of our offer to mothers within our boundaries. I think it's just Worcestershire, isn't it? Obviously, at this moment in time.
It is. Yes, it is.
Yeah.
Yes.
Thank you. If there's nothing else, thank you I'm looking around the screen in different places now. I know Amy, Louise, and there's one other somewhere, and I do apologise, forgot your name. Nikki, there you are, you've appeared. Thank you so much for coming along and being part of our patient story. Thank you for filling in the gaps and answering the questions. I certainly feel, and I'm sure board members certainly feel, as though they know a lot more, and certainly all feel sort of almost empowered to be those advocates that I'm sure that you want. And we hope that we will be able to maintain this service. But as Natalie reminded us, it was a pilot, and we'll just have to see how it goes. Thank you so much.
Thank you very much.
Okay, so we'll move on now to the Chief Executive's report. Sarah.
Thank you, Chair. Apologies, but there's quite a lot of important items in my report, so I will walk through and try and pull some of them out, but there's quite a lot in there. So as always, I've covered the national issues first. So of note, the National Long-Term Workforce Plan has been published for the NHS, which is fantastic. We've been waiting for this for a while, so it's really excellent that it's now been published, and it can very much inform our thinking about the people plan and our people strategy moving forward. You can see there's 3 key areas: recruit, growing the workforce; retain, embedding the right culture; and improving retention; and reform, working and training differently. So I am sure this will be coming through Workforce Committee, and we will be looking at our own documents to see if we're in line with the national strategy and whether we can maximise opportunities from it. So I wanted to draw that out first. On page 4, page 42 of Diligent, you'll note I reference the PCREF framework, the Patient and Carer Race Equality Framework. We have mentioned this before at board, and this is a framework to put patients and carers' views at the heart of what we do and to try and address some of the mental health inequalities. It's part of the mental health inequalities strategy. The key bit, there's a competency framework as part of the framework, but the really key bit for me is how you build that long-term sustainable conversation with communities around offering the right service and adapting the service to meet people's needs. So that's at its heart. When we brought this before, we said we would go away and look at the requirements when we've discussed it before at board. So it was just to note now that Natalie has agreed to be the executive lead for PCREF, so just want the board's support for that. There is, however, a range of areas within the framework, including some related to our people strategy, quite a lot related to our community engagement, as well as our quality portfolio. So Elaine and Sue are very involved as well, but Natalie is holding the ring on PCREF. Just wanted board support on that one. You'll also see that the NHS Equality, Diversity and Inclusion Improvement Plan has now been published. That's really timely because our existing EDI strategy needs a refresh, and we want to do a consultation to move forward with a new strategy. Our current strategy has just expired in sort of end of 2022. So this framework is really helpful as well to drive our thinking as we move forward with our draft strategy. 6 high impact actions, which you can see in the paper, are recommended as part of this document. This again will come through Workforce Committee. Do you want me to pause for a question mark or keep going?
I would keep going, and we'll have the questions at the end, Sarah, I think.
Thank you. We also mention the national letter around sexual safety of NHS staff and patients. We've talked quite a bit as a board around sexual safety of patients within some of our development plans and improvement work. This is also about supporting NHS staff who are subject to domestic abuse and violence. So again, we're asked to identify an executive lead, and Natalie has agreed to act as that lead to coordinate that work. Clearly, our safeguarding team will be very involved in this, and it will be reported through QNS. Just to note, you'll recall that a couple of days after the board last met, which is why it wasn't formally reported in May, on the 19th of May, NHS England confirmed that the NHS was changing from a COVID-19 response level 4 emergency planning response to a level 3, which takes it from national control to more regional direction. So the letter confirmed those changes and confirmed that step down. The COVID inquiry has now started. So just to note in the paper, Jill is our lead for the COVID inquiry and is keeping closely connected to any learning or conclusions that are drawn by the inquiry moving forward. Just moving on to page 7, just to note, and you'll be aware via F&P, that the NHS oversight framework is reviewed quarterly, and there is we received a letter to confirm the outcome of the consideration of our services, which was that we moved from a level 1 to a level 2 in Q4 of 22-23. At the moment, we're still on a level 2 Q1 23 to 24, but this will be kept under review. The reason we moved is to do with the Hillcrest CQC report and the need to keep some scrutiny around that, and to do with the I wouldn't say the non-performance, but there are some mental health system targets that we are struggling with, such as dementia diagnosis. So it was partly to oversee the performance improvement that was needed. Did include IAP, but we have made quite a lot of improvements in that area. But there are a couple of system-wide targets that still need support and improvement. Just to note in terms of our partners, Worcestershire Acute Hospitals Trust, that I've previously reported that Matthew Hopkins is leaving the trust at the end of July, as is the interim chair, Anita Day. So I want to wish them both well for the future. You'll also be aware that the Acute Trust Board has announced that they have agreed to join as a full member of the foundation group, which includes South Warwickshire University Trust, George Eliot Trust and Wye Valley Trust. Glenn Burley starts as Chief Exec on the 1st of August, and I've already got meetings scheduled with him to go through some common issues. But I'm very positive about Glenn starting and some of the opportunities that will bring around our partnership. I haven't mentioned the chair in my brief, partly because that goes through a formal NHSE process. So we're waiting for the outcome of that. I believe it might be this week, actually, and then we can formally confirm that that is all complete. You'll note that Hereford has partnered with Leeds City Council, which is a long-term partnership around the improvements they're making around their children's services. Also on page 8, just to note the CQC update. The board has had a number of conversations about this already, so you'll be very familiar with the content of the interim feedback from the CQC. So this relates, as you're aware, to the well-led review, which started in February and has run into June. As you're aware, we still haven't had any formal report from that inspection. So at the moment, the feedback in my report is about initial learning. emerging themes, if you like. And actually, when we get the report, we'll actually update our action plan in a lot more detail, because we'll be able to see the detail that sits underneath some of these comments. Myself and Natalie have had some really helpful conversations with the CQC to understand the nature of the comments that are being made. You'll see in my report I've outlined the key areas for completion. I'm just going to mention them. I'm aware the board have gone through these already. The first one was about the need for more constructive board challenge. The second one related to risk escalation and a CQC question about whether all of our risks were adequately escalating to the board, so a need to review the risk process. The third one was around pace of cultural change. We've also got areas around the need to make our culture more open. The CQC have a range of indicators around closed cultures. They are more common in any environment where patients cannot voluntarily always leave. They've raised a couple of the warning signs that are around the closed culture guidance from the CQC. So we've been looking at that in detail and doing a risk assessment to assess where we are on that. And there are some areas around equality and diversity with particular reference to race. They also noted a number of positives, which you can see there, which did include the National Care Notes outage and our attempts to, or our sort of recovery response, which was seen to be successful, which you can see there. So in response to the initial feedback, we have developed an initial headline action plan. It is a headline action plan, and the board will be aware that we're having a more detailed conversation in a development session to go through the action plan and make sure we're satisfied it covers all of the areas we think are priority. We've also done some other interim measures. We are in the process of looking at commissioning some external organisations to support us, particularly around the EDI and risk comments, and possibly to look at some of the cultural diagnostics that we need to do. So we're working through those, and we'll share those with the board in more detail. The key thing to say, as you'll be aware, is that we are absolutely committed to addressing the issues. We have accepted the areas that the CQC have raised that they believe need improvement. We've accepted them all as a board, and we're moving forward to make sustainable change. Just continuing on my report, on page 9, you'll see about the industrial action. You'll be aware that we've just finished a junior doctor strike, and the consultant strike starts today. Rob Cunningham is coordinating a lot of the action around the industrial action and can add if he's with us. I know he's got to dip in and out a bit for meetings around the industrial action. Thanks to the planning that's been done through Rob and Matthew and the team, and thanks to the positive approach our staff have taken, we have not had any significant incidents as a result of the industrial action in terms of patient safety, and we have managed. But you will, however, be aware that clearly there have been some cancellations, which we are concerned about because we've had to cancel some planned activity. We don't know until the action is complete how many staff were actually on strike, because, as you know, there's no obligation on staff to tell us in advance. But just to note that the regional and national picture appears to suggest that around 40 to 50% of doctors have been taking industrial action over this period. I think the view is that our figure might be slightly lower than that, but we won't know until the action is complete. And I'm sure if you've got questions, Rob will be able to add when I've completed my report. The other key thing to note about the industrial action is clearly there is a lot of concern about the risk to the acute trust of the doctors' strikes. So we've been working really closely with the acute to make sure the urgent care pathway is very effective, and that we have tried to encourage flow as much as possible to make sure that there is bed capacity in the acute. It's fair to say that our teams have done a fantastic job. So particularly around patient flow, particularly around patient flow into the community under Pathway 1 and into community hospitals under Pathway 2. We've seen some outstanding performance this week where teams have really wrapped around this challenge to make sure that we are doing everything we can to support the acute through this difficult week. The other things I just wanted to draw out, bottom of page 10 of the report, 48 of Diligent, just to say that we've been awarded a silver award in the Defence Employer Recognition Scheme, which is absolutely fantastic and recognises all the work that we're doing, led a lot by Sue and Sammy, our EDI lead. to support veterans, reservists, cadets and their families, and it's great to have that recognition of the work that's been done within the Trust. You'll note on page 11 we had the Senior Leadership Away Day on leading for inclusion. The feedback from that has been extremely positive, and there's been a lot of reports of practical actions happening following that. The only comment I would make, and my apologies, but the pledge that's in the report there, that's the inclusion pledge that we signed up to, which is based on the NHS Confederation Inclusion Pledge. We were asked as a board to make a statement. That statement, apologies, that was our original version. We made a couple of minor amendments to that. So just to advise you that the amendments were, we'd said to provide effective leadership to the organisation to educate, implement, monitor and sustain. And we had changed the order to say the betterment of patients, staff and partners. So just to tell you that those two minor amendments were suggested by board members. So there is a final version now, which I can share. And finally, just to reinforce Mark's comments, that to wish Steve well and thank him for his massive contribution. You've been a great support to I'll speak on behalf of the executives at this point. I know to the whole board, but to the executives in your leadership of finance and performance, but also your constructive challenge, ideas, questioning has been really, really valued by the execs, and we really appreciate it and wish you well for the future. Just for the board to note that Biraj will be taking over as the chair of Finance and Performance Committee, and you can see in my report there is a summary now of the committee membership and which NEDs attend which committees for completion, so that is all outlined in the report. My apologies that was long, but there's some really important items in there I didn't want to gloss over. Thank you, Chair.
Thanks, Sarah. Should we quickly do the admin first, which is, can board please approve Natalie for PCREF lead and also domestic abuse and violence executive lead? Can I have thumbs up and agreement for those?
Mark, okay. Can I just interject, because my question was regarding that. So can I ask my question?
Yeah.
I think throughout Sarah's report, there was an awful lot of things that required additional resource and commitment from people. And I was just going to ask the question, has Natalie got sufficient capacity to do those two additional roles? And has she got sufficient support beneath her to free up her time to do those two additional roles?
Maybe let Natalie answer that.
I was going to say, Natalie can answer that.
Yes, Tessa, I'm happy to take executive lead for both of them. They both span portfolios, so no doubt my executive colleagues who have key parts to play in this are fully on board as well, so it won't be a single person effort remotely.
I think your question is well founded, Tessa, so thank you. But I believe there is a saying that if you want a job get done, then give it to somebody that's already busy. So I think, Natalie, you fit that bill. OK, can we agree those two posts then? Additional references. Thank you very much. Which then moves us to questioning of anything in that report. I'll start with Jamie.
Thanks, Mark, and thanks, Sarah. Very comprehensive report. Just a couple of quickies from me. One is on PCREF. Can I ask Natalie if we approach this work as a collaborative endeavour with our partners in the system, possibly with the view of, I don't know how feasible it would be to have a system-wide PCREF rather than each of us having our own different parts of the NHS. It might be something that would be worth exploring at Mental Health Collaborative. Second point for Sarah on the workforce plan. Sarah's report, as ever, provides us with useful updates on national initiatives, and this one sets out Sarah says the priorities, the government's priorities for the NHS workforce. I don't want to be in any way negative or political on this, because this is a plan that's been received widespread support from everybody, because it's in some ways long overdue. We've been waiting for it for a long time, but there are aspects of this that aren't necessarily in the main government's messages on this, which we need to be aware of. For example, it's not a workforce plan for the care sector, even though many people were hoping that we might have a workforce plan that covered both health and care. So we're left across the health and care system with a large part of the workforce covered by this new plan, but a large part not covered. Also, I think we need to be aware that it's dependent on the NHS achieving up to 2% productivity improvements per year, which is well above what the NHS has been achieved. To do that, it will need very large capital investment that itself hasn't been approved. So I'm not trying to be negative, but what I'm asking Sarah is, without wishing to create a lot of work, when we have these reports, these updates on national initiatives, could we have a brief bit of commentary to show the proposal in context, and not just what the actual the government or the national NHS report is. This one, it has widespread approval, but it would be helpful if we just saw a little bit more of a rounded commentary on what the proposal meant for us.
I think you're getting nods from Sarah there for the commentary, but
shall I respond to both of those points?
I didn't know if Natalie was going to respond on the PCREF or system PCREF, I think was the question.
Yes, so absolutely, the Mental Health Collaborative will be essential in the PCREF work. The PCREF, very brief, has 3 streams. One is around our workforce, one is around our quality standards and how we make sure that minority groups have the same outcomes as non-minority groups, and then finally around system engagement and engagement with our population needs. So absolutely, it will be part and parcel of the PCREF work.
And just on PCREF, it's worth noting that following the discussion between Sarah and myself and the importance of PCREF, a non-executive director has been approached and agreed to be the non-executive lead for PCREF to assist on that work, and that's Vina. So thank you for that, Vina. And when I approached her, I said, I can't tell you too much, it's an emerging thing. So Vina will be part of the learning with Natalie. But the reason I mention it is the board are taking PCREF very seriously, and hence we've appointed a non-executive just to have an oversight and contribution there. I think that's. But Sarah, did you wish to respond with regard to the commentary on national issues?
No, it's fine. We'll look at whether we can include it. Obviously, I'm cautious of how long my report is already, but yeah, we'll find a way to just give a brief précis. Thank you.
Okay, thanks, Sarah. Sorry, Steve.
Thanks, Mark. My question is back to the workforce plan. I wouldn't ordinarily read a big, massive document like this, but I thought, given it was entitled a once-in-a-lifetime type report, I'd give it a good read. And obviously the areas that they're going to focus on, training more folks, etc., and reforming the sort of structure and the role responsibilities are the 2 biggies. I just wondered whether, from a recruitment perspective, our training and education partners must be gearing themselves up for increased places for training across the workforce. And are we having early discussions with them about what that may mean? Because obviously, if you're being trained in this part of the world, you're more likely to stay. So are we having discussions about that with partners? And also on the role reform, do we have to wait for guidance, or can we go further more quickly in that regard? Again, around the recruitment, but more importantly, the retention.
Can I start, and then Elaine might want to come in? Just to say, in terms of the university, yes, absolutely. In fact, I was talking to Professor Green about it the other day, and the university are being very, very proactive about this. They'd obviously seen kind of a lot of comments about what might be emerging, so they've been very actively thinking about how they could respond. I think it's fair to say, and I don't want to talk for them, but I think it's fair to say everyone's biggest concern is you can put a lot of places in, but whether you can find people to apply for the places is where the challenge is. So I think the university are definitely getting themselves prepared and willing to expand places at a pace. And obviously with the medical school development, they're in a very good position to do that for a number of our professional groups, which is really positive. But I think we're going to have to really work together to get across the, why come to Worcestershire? What can we offer? What would be different? How do we attract people to actually apply for those places? I think on the roles, again, I think our university is really proactive. So I think if we have any ideas about new roles, they're more than willing to think about what they could do to develop the training that might be required for those new roles. So I think we can move at the pace we're comfortable with around the roles and work with the university on the training. But Elaine, do you want to add?
No, it was pretty much what I was going to say, Sarah. We are having some additional discussions because whilst our university partners may be very proactive, the issue is getting our students to stay in the area in amongst the challenge of affordable housing and not great travel infrastructure. So I did attend a meeting with local authority partners a few weeks ago just to highlight this and to just make a plea really to think about how we might be able to influence some of those wider, and I use the term big P, political agendas about this. There is a big emphasis in the workforce piece around apprenticeships as well, and what we're going to do and how we might do that as a system as well. But it was the point I was going to make was essentially what Sarah was saying. But our university partners are very alive to the challenges, but it does follow with they may study here, but can we get them to stay here?
Thank
Mark,
you.
Mark, sorry,
yeah,
can
go
I
ahead,
just come back on? I just wondered, given the significance of this, whether it should be the subject of some kind of future board session on how we capitalise with our partners in this regard, because it seems to me that it is our greatest challenge, isn't it? I just think we should make it a very significant element of how we take the benefits and get the advantages that we need for our workforce and obviously our services thereafter.
Yeah. No, you'll get no disagreement from me. We're already talking about it at a system level, about what we can do as a system. The fly in the ointment there is we're all kind of co-located with each other geographically. So we're all talking about probably the same workforce. How do we put some good practice in place that doesn't have us competing with each other, obviously, or less so? But yeah, it would warrant a wider discussion.
Thank you, Elaine. Before I move to Tessa, could I just check, Sue, was your point around this university issue or a separate thing?
It was a little bit about the university, and it was based on a patient safety visit that Elaine and I made on Monday to podiatry. And for example, Worcester doesn't offer podiatry. All our podiatrists are being trained at the University of Wolverhampton. They have an undergraduate cohort of 12 at the start of a course, which then drops down to 6 who graduate. And we are all looking for people from that area. So I think we need to spread our net very widely, and I think what Steve was saying there on having something really focused on this and thinking about how we engage with further education and schools would be really, really interesting.
Thank you, Sue, and that certainly plays to a system approach, doesn't it? Tessa.
Thank you, Mark. I think my question probably is a sort of conglomerate of reflection and question. Throughout Sarah's report, there were some big national initiatives. More locally, we've got the need to refresh our EDI strategy. We've got the CQC report that we're expecting and is pending. And for me, there's an issue about resource across the whole piece, really. I'm not expecting a detailed answer to this because I think it's a big question that's going to take some big conversations. And I know we'll pick the CQC piece up later in our development session. But increasing education training places at university is one thing, but are we confident as an employer we have sufficient mentoring, supervision, training opportunities within our trust to bring people in and get them qualified, and in a way that makes them want to stay with us? Are we confident that we've got the resource within our EDI and our OD cultural piece moving forward? And I know Sarah mentioned bringing in some external support for that. But I think for me, the biggest one is going to be the CQC action plan, which by its very nature will be huge. They always are. And do we think we will have sufficient resource and capacity to deliver on that? I'd say not expecting a numbers base, but are all these things being pulled together? Because I think resource and capacity are our biggest challenges.
Just a little subject matter for you there, Sarah.
Just to say that we've got an emerging list of where we think the greatest priority is for resource focus. It's going to be a challenge because you know how financially challenged we all are to deliver the existing efficiencies, and the system financial position means that any spend in our organisation is monitored now between at system level and regional level, which Rob will talk about no doubt later on the agenda. So it's going to be a challenge, but what we've been doing as executives, as we've talked through the action plan and looked at where we think the focus needs to be, we've been collating a range of areas where we think additional resource will be required. And I'd like to, when we go through the action plan in detail later today, I would like to share that with you so that we can see if we think those are some of the correct areas. There's then a harder conversation to be had about what that means to our overall financial position, because at the moment we're forecast to deliver a surplus. If we invest a lot of resource in these areas, it's going to have an impact. So we just need to decide how far we want to go, whether we've got the priority areas agreed, and what it means for our financial position, that we're all comfortable with that balance, if you like. So I don't know if that helps, Tessa, but we will come back to it later.
Yeah, that's great. Thank you, Sarah.
Just one comment I would add, because we do use this term surplus, which I believe Rob will tell us is technically correct, but that money is spent allegedly already because it's into the system. So it's not a surplus for us to just determine what we'll spend it on. It's actually agreed at the beginning of the year that our budget would provide this into the system to support other system partners. But I'm sure that'll provoke some discussion in the future. Sarah, could you just comment about ICB liaison you have over CQC, because I know you've been discussing.
Oh yes, so my apologies. I should have mentioned that. Thank you, Mark. I should have mentioned that. So so we've kept the ICB fully informed in all the CQC conversations, and Natalie and myself are in contact with Simon and Kath Cobain, Director of Nursing in the ICB, and Simon Trickett, the Chief Exec, to share with them where we are and what the feedback is to date. So that's all been shared. They have very kindly offered to support our improvement plan, and it links to your capacity problem and question, Tessa. They have kindly offered to enable one of their senior leaders to be released to come and work with us full time to support us doing that improvement plan. So that is really appreciated. We're just finalising the sort of HR elements of that, but we really appreciate the offer of support. And I think that will also add some capacity, because what we feel really strongly about is when we get the full report, it's going to be quite a detailed action plan. There's going to be a lot of things that need progressing. And some of these topics, particularly things like cultural change, are not easy to resolve and they're not small. So actually that capacity around helping us move all that agenda forward is really important. Thanks, Mark. I should have said that, and that's really important.
Thank you for your support. Your report, which contained quite a lot of meaty items. The only thing I was going to add, if I may, is from the chair to add my thanks to both Anita and Matthew at the Acute Trust. From a chair's point of view, Anita took over the trust as an interim at a particularly difficult time and has steered it through to the leadership changes, which is seeing her leave the trust. I'd like to add my personal thanks to Anita for her support and friendship over what's been now the last 4 or 5 years, but certainly in her time as chair at the trust, and personally wish her well for whatever she's doing in the future. Okay, thank you for that, Sarah. If we can all note that report. And move then on to Board Assurance Framework and the High Level Risk Register. Jill.
Yes, thank you, Mark. I just thought it'd be helpful if I just outlined before I talk about the board assurance framework. Sarah mentioned that we are getting some support in terms of gaining assurance and best practice from an external source in terms of our processes of risk management, and I'm just in the process of agreeing the terms of that, which is going to involve a desktop review of our process and risk management strategy. And for that reason, normally I would have brought the risk management strategy back at this point for discussion with the board as part of the annual review, but we are just going to delay that so that we're doing the work around risk management, which involves both the board assurance framework and risk management more generally in the organisation, and so it's going to be slightly delayed coming back at a subsequent meeting. And that work will also involve some survey work with managers across the organisation about how they understand the process works, and about how we report risks through the organisation and how those are escalated. And so obviously what we have presented here is the board assurance framework and the higher level risks. And I think we have an ongoing debate about how sometimes there's a lack of consistency as to whether some of those risks are appropriately strategic and whether some feel very operational and are scored at a different magnitude. And it's hoped that some of that work will seek to address that. But what you have here are the higher level risks with how they have changed over a period of time. What you'll see are the highest level of risks are relating to workforce issues, so probably not a surprise on that, although we have one very specific high level risk which I question feels very operational in terms of speech and language therapy and whether that really is at that level. But we also have the board assurance framework, which is of course the areas that are going to potentially stop us from achieving our strategic objectives. The processes of risk management do continue, but as I said, they are being reviewed, and we're looking to see as to whether we can make improvements on that and make sure that we have appropriate support, training and challenge for people that are undertaking risk management on a day-to-day basis. I'm hoping the papers are self-explanatory, so I'm happy to take questions on the subject of any of the items, although I would obviously ask, as I always do, that the board approve the current version of the board assurance framework, which has updates and changes identified in red. I can see I've got lots of questions.
You have. Thank you, Jill. We'll start with Sue before Tessa. Sue.
Well, just one of the themes at the NHS Providers Conference that I went to was about sharing risk registers and common risks across partnerships and systems. So I just wondered, when our sort of dashboard is looked at or our paper exercise takes place, whether that will also involve other trusts and thinking about what their risks are and where we have commonality.
Do you want to deal with all the questions, Mark, and then I'll pick them up?
Okay, yeah, yes, thank you. We'll do exactly that. So, Tessa.
Mine's just a comment. I'm just trying to prove I read it all. On page 62, Jill, on risk 1294, it's got a score of 4 by 4 that makes 15. And I know my maths isn't always very, very good, but I think it's 16.
You get the points for reading every word and figure by the look of it, Tessa, as well. Thank you. Jamie.
Apologies for raising a query on a very operational issue, but it is listed as number 1 in the top ongoing risks, 1295. And I noticed that when this was brought to our attention in the May board meeting, Matthew felt that this was a very temporary issue in the service and would be resolved quickly. I'm just wanting an update since it's still here 2 months later at the same level of risk.
Do we pick that one up before we then move to Martin and Jill's general response? Matthew, could you respond to Jamie, please?
I But thank you, Jamie. We discussed this week in Children and Young People's Integrated Governance Committee. The root cause of this risk, just to remind people, was that during COVID and after COVID, some of our outpatient facilities were used differently. This resulted in equipment being moved around from place to place. Consequently, some of the equipment was temporarily lost, as it were, from the equipment register and didn't undergo the regular check. Some of it was misplaced. We've addressed this now with our estates team and with the people providing each of the clinics. We're confident as of this week that this is now a resolved issue and this issue will now be removed from the risk register.
Thank you, Matthew. Martin.
Thanks. Jill, I was just going to ask if the review that is being done will take into account the how we deal with risk at the board level and how it's spread between the committees and bring together at the audit committee, because we've tried out some new stuff in the board effectiveness review. It'd be worthwhile getting an insight into whether we're doing that right or not. I think the other element is just to pick up what Sue was asking about, is we are looking at and have been invited to each other's audit committees now across the piece. We're just trying to schedule that, and alongside that we will be sharing the BAF and risk across the piece.
Thanks, Martin. Jill, do you want to respond to those points?
Yeah, so as a system, I am meeting with my counterparts across the ICB and both acute providers, and the provider that we've identified to do the work with us has actually also worked with Worcestershire Acute and with the ICB on areas of risk. And so there are some commonalities there. And one of the things that we're trying to develop are some common risks across us that become system risks. So issues around urgent care is a very obvious starting point, and we're starting to try and bring together some common themes and some common language around those risks. So I think that it's very much early days, and we're also looking to other systems who are in similar positions about trying to have system conversations about risk. So it is a very live area. On Tessa's point, thank you for that. Obviously, that's an error at my end, and we'll obviously sort that. In terms of the review, Martin, we are at the moment just agreeing the terms of that, and I think that's something that's quite relevant to add in terms of looking at our general process about risk management and how we manage that. So I don't think that will be a problem to incorporate at all. One of the things that we are asking as part of it is not just looking at our process, it's also, have you identified best practice from elsewhere? And I think that encompasses some of the points that you're making in terms of how does Trust Board gain assurance both about the very operational level and escalation of risk, but also through the committee structures and how we make sure that there is a coherent way of managing that. So certainly make sure that will be included within the review that's been undertaken. And just so board is aware, we are looking at having a joint board and senior leadership team discussion about risk management led by the external provider in October, bringing together probably half a day on risk management and how we do that through a senior leadership team leading up to board as well. So I would hope that would also help in the process. You're on mute, Mark.
Thank you. Can we as a board approve the BAF as presented? Thank you. Can I just make a couple of requests, please, Jill, around this? Obviously, as you can see from the questions and your explanation about risk management, it's an area that's risen up our agenda, and there's a lot of work going on. Can I ask a couple of things? can you give some consideration to how we as a board can assure ourselves that our teams are utilising the process effectively? Not an easy thing, you know, because it's relatively simple to see processes and make judgments about that, but we need to in some way assure ourselves that our teams are actually using it effectively and risks are rising up to the right level and being used properly. And the other thing I'd ask is, can you give some consideration as to how board risks is brought to the attention of board as well? Like Matthew just indicated, there's a risk that's going to be removed because we've got a number of risks. Can board be kept appraised as risks are taken off the risk register? Could that be highlighted as well in future reports?
That should be evidenced in the trend report, where you can see that risks have been removed, but I'll find a way of making that absolutely explicit. On the first point, that is very much part of the work that we're commissioning, so that board have greater assurance about that.
Thank you very much indeed. Thanks, Joe. We move on now, Sue, for a quick canter through our strategy and partnerships and the areas that we've identified that we wish to keep topped up on. Sue?
Yes, thank you, Chair. So just to remind people that this is an overview of the progress against the 6 key priorities we agreed as a board last October. There are many programmes across the Trust that run through PMB, and a more detailed report which includes these 6 also runs to finance performance. So many of these programmes have already been overseen by quite a number of us on the gallery in more detail. So this is just picking up the high level. It picks up the accomplishments since the last report. It picks up the risks and the next steps. You'll see that there's a lot of progress being made, certainly around the metrics around recruitment and retention. We've got the ongoing push on virtual wards. There's a bit of a reset on the children and young people service transformation. We've made some good areas of recovery, and we need to have a look again about what that will mean in terms of progress over the next 6 months, 12 months. We've started all of the Getting It Right First Time programme now. All of those work streams are running, and we have received an update around that programme from John in previous board sessions. Community mental health transformation very much mainlining now to business as usual alongside IAPT. Both are key priorities for the board, so we wanted to keep those in the report till we felt that there was a level of sustainability and that recovery we were assured was actually going to be maintained. I just wanted to flag, though, that there's a lot of planning in the system about the priorities for 24-25. So we'll be working those through a task and finish group, which myself and Rob Mackey are part of, and that will then set some of the priorities we'll need to look at as a board for 24-25, which we would normally do in the October-November time. So this report I will take as read, with the caveat that clearly we've made good progress in some areas, and we're at a point now where it'll be really timely in the autumn to look at what we think the big ticket items are for next year.
Thank you, Sue. A couple of questions, Jamie and then Tessa.
Thanks, Sue. It was just a query on the assurance level that's quoted for the Children's Transformation. We did look at the Children's Transformation programme at F&P a couple of weeks ago, and I'm pretty sure we gave it an assurance level of 3, not 4. I'm not sure I'd support an increase to 4 at this stage. I don't know if this is an error. There is good progress being made in the programme, but it's getting the basics right. What we're waiting to see now is the vision for actually transforming the service, including looking at system-wide solutions, not just fixing the admin issues. I think this is alluded to in Matthew's report later on. So it's really just a query that assurance level.
I will go back and triangulate that, Jamie, and update the board accordingly. I think we are now in a position, as I flagged earlier, we need to start to separate out now what is kind of internal housekeeping, as you say, and that recovery that we made to date, and then what is the transformation programme that's much more aligned to the system pathway transformations that we need to make to ensure that that's sustainable. I don't know if Matthew wants to comment further, but that's the piece of work that the PMO is going to undertake with Sonia, the new Associate Director for Children and Young People and Specialist Primary Care, and Matthew as SRO over the next month.
Thanks, Sue. Tessa.
Thank you. I've got 3 comments and questions. On priority 1, I just wanted to flag that the recruitment and retention piece, I'm sure, will be part of the Extraordinary Workforce Committee meeting at the beginning of August, when we look at the people plan, staff survey plan and the recovery plans. So I think we should get a better idea of how we're going with that from a assurance point of view. On priority 3, which is the children and young people's one, there was a mention about future admin and clerical model, and I just wanted to check that if there is a service transformation or an action plan being delivered, are we mapping that against our workforce plan in general, and can we be sure that in all of these transformation areas the EDI questions are being focused on? And then finally, on priority 5, there's a comment about retention in newly recruited roles and how long people are staying. And I just wondered, what are the reporting metrics going to be on that? And are we going to be able to learn lessons across the piece where other service areas are recruiting significant numbers of staff to new roles?
I don't know if Sue, Elaine, there was quite chunky bits there. I don't know who will respond to that one.
Sorry, Elaine, I was just going to say, shall I, if we've got the workforce model around children and young people, which I think it's Elaine, and then the retention of new roles, and I'm happy to pick up some of the EDI processes, because we've taken a look into the Programme Management Office as part of the Programme Management Board reset to ensure that we already do complete equality impact assessments as part of all service change, but actually is there more we can do with some of our softer intelligence, patient experience, community engagement, that actually brings that more to life right from the outset of every project. So I'll hand to Elaine for the details of the workforce elements.
Yeah, around workforce planning, but primarily getting better quality data around our levers. We're currently refining that. I hesitate to say we may be a little more directive about completion of a more qualitative exit data that gives us better information. So we're refining the pro forma around that at the moment. We're also encouraging our managers to have more timely conversations where staff are potentially thinking of leaving, haven't necessarily vocalised that, but it needs a different kind of conversation with that staff member to perhaps head it off before it goes down that route. By the time they've handed in their notice, lots of opportunities potentially have been missed. So we're working to get managers to be more proactive about that. And then there was something else you asked, Tessa, which I can't remember.
It was about that recruitment, and are there any the retention of newly recruited, and are there any lessons that we're learning across the piece, I think, Elaine?
Yeah, so one of the things that we are, and so I've already started doing, is a 3 months in, what's it like? 6 months in, what's it like? And rather than waiting past the seeming probationary period, just having those conversations earlier and picking up any lessons learned from that.
Okay, thank you. Janet.
Yeah, thank you, Mark. My question was about priority 5 as well, but it was actually about the issue around care notes and the outage and actually affecting measuring performance. I think there's a comment there that this large piece of work won't be completed in full, and it's work on top of people's existing responsibilities. So it was really to know what's happening with that. But also, when I looked at the next steps, there didn't seem to be anything there that actually was going to address that issue. So I was hoping that it wasn't just being left dangling.
I think this is one probably for Matthew, who chairs the programme, but I think you're referencing the top of Diligent, page 79, around the outage. Is that, Matthew, are you okay to take that?
Yeah. We've had to take a proportional response to the restoration of care notes. So, their priorities, top priority was to ensure that all clinical records were fully restored, so that every patient had a full clinical record, so that no clinical information was lost. And that has been completed. And we've had to take a view on how much work we undertake to restore all possible data points within care notes. And we've had to take a proportional response because it would probably take many people many years to go back and translate all of our downtime documentation into data points. So, for example, if somebody was in an outpatient clinic during the downtime period and an outpatient clinic letter was uploaded, in care notes that would also generate a parcel activity. Uploading the letter on its own doesn't do that. So what we've had to do is we've had to say, okay, what's crucially important for which services in terms of data restoration. So we've chosen to go through services and restore as much as possible that's practical and convenient to do, and B, where we're reliant on clock stop information to provide a proper narrative about the patient's journey. So we're prioritising things like the Starting Well service, where it's important to know what happened to a child at what points in their care journey. For other services, we have had to accept that some data, not clinical information, some data may well have to be a write-off. So in some types of mental health and children's services, we will not have full data ever for the period of downtime, and the amount of resource required to restore it would be disproportional. And we've notified NHS England of this position, and there's a similar position being taken by other trusts that have had the care notes outage as well.
Thank you, Matthew. If there are no other questions, I think I'd just like to reflect to board that those priorities will be impacted / discussed along with what's going to fall out of the CQC report, obviously, because that action plan will be our priority, but whether that's then subdivided into various priorities, I'm not sure. So that discussion Sue talked about for the reset for September will include our CQC work, which is an obvious thing, but I thought I'd state it anyway. Okay, thank you very much. So if we move then on to talking about CQC work, Hillcrest improvement plan. I don't know who's going to kick this one off, but obviously our triumvirate have got their names against it.
Thank you, Chair. I'll begin and I'll draw in Natalie afterwards on quality issues, and John may want to comment on medical staffing issues. So the paper is an update on the Hillcrest improvement plan and some of the associated themes around that. The plan's now been in place since July 2022. We're on version 6, which is the current iteration. We've extended the plan slightly now to capture common themes that are across adult inpatient wards, so slightly wider than Hillcrest. Just a reminder about the constraints of the implementation plan and what it can hope to address. So it can only really address issues within its operational scope. So Hillcrest remains an isolated unit. It's a mental health ward on its own with no support around it. The design is quite poor, realistically, for an adult acute inpatient ward. It certainly wouldn't be built that way if it were built now. And we still have significant recruitment challenges, which are especially expressed at Hillcrest. So the aim of the plan is to deliver the best care possible within these constraints and mitigate risks that have been identified internally and also by the CQC. As I've noted in the paper, the plan's on track with a few minor exceptions noted. We've been able to step down the formal risk summit approach now to normal service level integrated governance routes. But the executive team, so myself, John, Natalie and Elaine, continue to meet with the leadership team regularly for support, feedback and guidance. Within the paper, just draw your attention to a couple of pieces of targeted procurement work, which are now nearing completion. So one is the cultural improvement programs. We've selected a preferred supplier because the tender value is above the 50,000 limit. It is with NHS England for oversight approval now. The patient experience project on-site advocacy have been selected as a provider to work with us to enhance our onboarding of knowledge gained from the service user experience as well, which Sue may want to talk to if you've got any more detailed question. Hillcrest has now got its own quality dashboard, which I've included as an appendix. Natalie may want to speak to quality issues after I've given my update. On the area of recruitment, I've said in the paper has been as expected, which is to say, despite our best efforts, it's been slow. It's progressing in the right direction. There are some new registered nurse starters commencing in September, so 3 new Band 5s. We've had 1 new Band 6 join us. We're hoping another one is joining us following a recruitment round this week. And we've got 2 new healthcare support workers and 6 CSWD healthcare support worker development posts in the Hillcrest establishment now. However, the outturn of that is still that we have a 57% vacancy, so it's still significant. Our booked agency solutions have been successful, certainly in some ways. We've had good fill rates with low numbers of staff. So that's the stability we were looking for. We were previously using a very large number of staff. Where we wanted to get to was that we had a smaller number of kind of long-arm staff. They worked with us almost exclusively. We treated them as our own staff, incorporating them into the life of the ward and managed them as if they were our own staff. That's been reasonably successful. We've used only 15 registered nurses, whereas previously we were using 100 plus a month. But there have been some challenges within that which we have to be transparent about. So we've had 5 practice concerns raised. Not unusual with agency staff working with us. We don't, they're not subject obviously to our selection process. And there are current discussions at the moment between ourselves and our lead agency about the range of duties that some of the staff are performing or not performing. The arrangements at present are in place until the end of September. Realistically, they would need to be extended until at least the end of the financial year due to slow recruitment. We've got 5 substitute beds open at Wrexham at the moment. I've detailed the quality oversight arrangements in the paper. I would draw board's attention to the fact that the length of stay in those beds is above average. It's less, far less than other out of area placements though, and probably actually reflects the needs profile of some of the patients who've been moved on to those beds. We've been very selective about moving on male patients who've got longer term acute needs, are detained under the Mental Health Act and are generally waiting for a complex piece of ongoing care. So you would expect some of their care journeys to be slightly longer anyway. We're reviewing these arrangements in July, well, this month, we're reviewing them at the moment. So we're reviewing our current capacity at Hillcrest, the staffing arrangements and the arrangements with T. Grosvenor at Wrexham. We're proposing a plan, we'll be proposing a plan formally in August for what reopening to 14 beds at Hillcrest would look like. My suggestion would be this would be subject to staff side support. So I would like to take it through JNCC. I would like to ensure that staff side are in support of this proposal, given the very strong feelings of staff side that have been expressed previously about staffing levels on Hillcrest. So in conclusion, from an operational perspective, the Hillcrest Improvement Plan is delivering the operational, environmental and process improvements that are immediately required. Block booking has delivered us a stable workforce, but that needs to be subject to quality review now. The substitute bed capacity, although not ideal, is acceptable to patients and is being well managed. Overall, though, delivering acute mental health care in Hillcrest is challenging. It is a poorly designed environment. It doesn't meet modern standards for acute inpatient care, and its isolation from other support, its long-standing recruitment processes mean that we probably should be thinking at this point about delivery location, especially given that neither Hillcrest or Holt, so the equivalent acute ward in Worcester, they don't operate as locality wards, and they haven't done since 2017. So that's the operational update for the improvement plan, and I'll hand to Natalie for any quality improvements, and then subsequently to John for any medical workforce.
Before you hand to Natalie,
sorry,
in the interest of efficiency of our meeting, I'll take the 3 questions, which may then draw in Natalie and John to the questions. So I'll propose the 3 questions I'm showing, and then if necessary, move on to Natalie and John. Steve.
Thanks, Mark. I was drawn to the dashboard at the end to see the impact, and I know that Matthew has caveated quite a lot of how things are going, whether we're on the right track, and whether it's having the desired impact. But you would be forgiven for concluding that actually not a lot has changed from an outcome perspective in terms of vacancy levels, in terms of the mandatory training, completed appraisals, the sickness levels. And so, I asked the question, is it really working on the ground? And the other question I was going to ask is whether these kind of quality reports we could see at board level by exception if we agree some threshold levels that things are worsening across the range of indicators. And I just wondered whether we could think about what those threshold levels are and our tolerance for whether they're going above a certain threshold that then highlights to the board that something may need to be flagged and actioned.
Matthew, would you like to come back on that one?
Yes. So what I would say about the improvement plan is that it was a plan primarily focused on inputs initially, because we had flagged a number of environmental concerns that have been addressed through the plan, some care delivery concerns, so the things like implementation of risk assessments, care planning, planned patient activity, aspects of patient experience, and those have all been addressed through the plan. The plan to decrease the number of beds tactically was to help us manage within the staffing levels that we've had. So we've done that. We've done that safely. We've done that without adverse incident and with satisfactory patient experience. So those are elements I think that demonstrate sort of the success of the plan. So some of the changes to things like vacancy level, I think realistically none of us expected that to happen quickly, and that's why we sought substitute capacity, why we looked to bring in 2 agencies for a group of staff to work with us as if they were our permanent staff, because we knew this was going to be a very, very slow pathway to recruitment. Some of the other changes in incident recording, our belief is that there was certainly some underreporting or at least poor triangulation of incident reporting at Hillcrest. Some of that was because so few staff were permanently working there. So HE staff didn't tend to put incidents on the reporting system. And it was something that was also flagged to us by staff side and CQC. So some of the change in incident reporting certainly has been due to the fact that more incidents are being reported at probably a lower threshold level than they previously would be. But I'm certainly happy for Natalie to fill in any detail around that.
Could I just come back on that, Matthew? I wonder whether we should have more regular feedback from service users and their families, as opposed to using compliments and complaints. Under these circumstances, do you think we could be thinking about Survey Monkeys or whatever form in order to get more direct feedback as to how it feels to be a user of the service on that facility, and that gets seen by the board as an added level of assurance? Because on the surface things, the indicators just, to me, don't look as if they're moving, and notwithstanding the point about lag here, and very significant lag that you'd expect, they just don't seem to be moving. So I don't get assurance from that, is the point. But maybe I'm being overly fixated on those indicators.
Should I jump in there? Is that okay, Matthew? So absolutely, Steve. So that's exactly why we've commissioned on-site advocacy to help us scope out what would good patient voice, carer voice look like on an acute inpatient ward. We have a suite of means of getting that right now, but that's from a very NHS perspective, and we've all acknowledged that we don't think that's doing what it needs to do. So community meetings, FFTs, QR codes, writing to carers. We've tried a couple of things that, as you said, haven't really impacted. On-site are a really well respected advocacy. They do our mental health advocacy. Patients report really positively about them. So they're coming in for a 3-month period. They'll be spending a day a fortnight on the 2 wards, really to get to understand with that patient and carer group what would that look like. That's their expertise, and then they will guide us and advise us. This is what we recommend you put into place to make sure the patient and carer voice is routinely and regularly listened to and acted upon. That's the on-site advocacy project. And I guess just to emphasise that the dashboard shouldn't give you assurance with this data that things are improving. I think it gives us assurance that things are stable, but absolutely the measures so far haven't driven significant change. And it's capturing some of the softer information. So, for example, I know there's a much more robust activity programme that patients are telling us is much more positive. They're engaged in activities. So it's how we collate that softer detail that the on-site will really help us with.
And just before I move to Tessa, to say this afternoon session will be touching upon patient and staff voice. And so that'll be part of our discussions this afternoon, which plays into this. Tessa.
Thank you, Mark. My question's around the workforce piece. We're predicting a 2% increase between July and September. If you put that into a recovery plan trajectory, I'm thinking it's going to take probably several years to get to an acceptable level of substantive staffing. So I was pleased to hear Matthew say that the block booking of agency, despite the fact that there are some challenges around what they can and can't do, and that's being tackled, is essential. I just wanted to reflect that given that, I think the proposal to increase beds is too soon, because I don't think we have made sufficient progress on substantive staffing and got a sustainable substantive staffing model in place that would give me confidence that it's okay to increase the number of beds again. I don't think that has for me, that hasn't given me any confidence that we could go ahead with increasing the beds.
Just on that one, Tessa, that will be a discussion. That will be I think in the recommendations it mentions discussion of that nature coming back to the next board meeting. So that thought and that thinking will pull out there. So I want to ask Matthew to respond to that now, because that will be part of our discussion at the next board meeting. Martin.
Thank you, Mark. And I agree with Steve's comments about the dashboard. But thanks for the discussion. What I'm curious about, though, Matthew, you mentioned the culture change programme, and I really struggle to see how you drive a culture change programme that is meaningful with a 57% vacancy rate. And at what point are we actually going to initiate that to drive that culture change, or is it? What are our plans? Because I can't quite work out what that's going to do.
Before you come in there, Matthew, this is all part of a bigger picture that's emerging. Remember, folks, that and what I was going to say to Matthew in that update that coming back to the September meeting must be something about the long-term viability and sustainability of a single isolated unit in Redditch, which I know has been the subject of discussion around the piece already, but I'm assuming that type of discussion will be brought back into board in the September time. I'm sort of looking at Chief Exec, and I think that's the intention. And of course, the crux of what we're discussing here is the fact that we have, as Matthew rightly identified, an isolated unit that is environmentally not really that fit for purpose for which we're using it, and hence it driving the poor staffing issues, which means we can't get to the cultural issues, etc. So I think a lot of what he's discussing actually plays into the long-term viability and future discussions, which I know, or I think we are going to be having in September. Is that right, Sarah?
Yeah, just to confirm, the GIRFT work programme around redesigning the acute inpatient pathway will bring some recommendations back in September, which will look at these issues of, we're doing everything we can around Hillcrest, we're not shifting the dial enough. So actually, what are the longer term thoughts around the pathway moving forward? That might be why John's got his hand up. But yeah, that's due to come in September. So we'll pick up the broader strategic thinking then.
So I think a number of these things that Martin raised, that actually have all been raised, will sort of play into that longer term strategic solution rather than what we have at the moment. And this plan, I think Matthew indicated, is more of a sticking plaster stability plan than we all accept the longer term of Hillcrest can't be cured because of the environment, apart from many other things, and that'll be picked up in September. John, did you wish to comment on that, the GIRFT, before I then move to Elaine, who's probably got a separate issue to the GIRFT?
Yeah, I've just got a few more observations to make, Mark. So let Elaine go first, and I'll come in.
Okay, thank you, John. Elaine.
Thank you, Chair. I wanted to just note that in amongst the patient experience is the staff experience, and it wouldn't be overstating to say that we have a challenge around culture at Hillcrest, and which is obviously going to impact on the level of recruitment. People talk in an organisation, so whilst we're putting a lot of effort into recruitment and trying to get our band 6 roles filled, people will obviously, the next thing will be, what's it like to work there? And we know that there have been historical challenges, which we're working with, but that is a contributory factor. The physical environment, the staff relationships, and I have to say the leadership team are working really hard to drive that forward, but it's not an easy ask. And great that we've got a consultancy coming in to work with the leadership team and the wider piece around culture, but the two things impact on the other. So I think it was important to make that point and to pick up, and I think Martin started to speak to it, getting a critical mass and a movement behind this is important, but we're not going to get it overnight. I think we're doing lots, but the dial is moving very slowly. But I wouldn't want to underestimate the impact of the physical culture in which staff are working at the moment.
Thank you, Elaine. John.
Thank you, Chair. I continue to have some concerns around Hillcrest, but also have observed some very positive developments as well. My concern continues to be around recruitment, and this is quite a wicked issue for Hillcrest because of the reputation and that comes with Hillcrest. The people who have actually applied to work at Hillcrest have done so with an intention to come in and make an impact and turn around things. So it's not attracting your usual staff member who would be looking for a job, if you like. We still continue to have a heavy reliance on agency. However, I think we have gone down the approach of block booking some agency staff and treating them as our own in terms of development and looking at improvement plans on Hillcrest. However, more recently, I think the local leadership team on Hillcrest have made some provisions for the lead agency director or someone to actually come onto the ward and work with them, because sometimes it's just quite difficult to convince our agency staff to kind of buy into the day-to-day working of the ward. So that's an extra thing the local leadership has done, which is quite good. The environment still continues to worry me, and not just the environment, but also the location of the unit. And this is where probably the GIRFT work will be looking at how best we provide a place-based acute unit for the county of Worcestershire. Also, because of its location and isolation, I think there are considerable patient flow issues, and having a unit in Redditch having to communicate with other units across the system is quite difficult, which is leading to quite a few problems. There are, however, quite a lot of positive developments. I think after a long time, we have a good local leadership team who are working jointly to embed some processes, and they are leading with the values that we want them to as an organization. As you know, culture is both processes and people. So I think the processes are being put in place, but it's taking people along that is taking time, and that's probably no surprise to anyone here. In terms of the medical establishment in particular, we've always over-established Hillcrest. Even when it was an 18-bed unit, it was over-established. We have maintained that 18-bed establishment even when it's gone down to 10. So there is adequate and even substantive medical establishment on Hillcrest, where we used to have locum establishment in the past. So I just wanted to add those points in particular. The GIRFT work, I think, needs to continue as per plan. There will be an options paper which will be coming around, which will be in draft in September and will be discussed in various forums over the next few months. But I think we need, absolutely right, we need to consider how we respond to the Hillcrest quality concerns, but also take into account an options which will be coming out of the GIRFT work and how it both fits in. So I'll stop there, Mark. Thank you.
Thank you, John. I think this is as we all know, a very wide piece of work that isn't just isolated to one place. It pervades much of what we do as a trust, and we're learning all the time. I think the points to remember on this, as my takeaway, is, as Matthew said, the plan is about inputs to stabilise. That has happened. There is some stabilisation, so i.e. there hasn't been any worsening. That isn't exactly a target for us, is it? It's not exactly a very good aspiration, but it's a first starting point, and that's where we are with that. Recruitment is always going to be difficult, and as John has just alluded to us, there are certain things we just can't change. We can't change the isolation, we can't change the environment, and GIRFT will be coming up with some options or proposals which we will be examining. So this is a case of a sticky plaster to try and maintain some stability whilst the GIRFT work produces options for board, and that is taking on more and more importance. And I think, I'm not quite sure what we'll see back here in September, but in the recommendations in the paper, there are a number of things that it says will be brought back to board. One of those things that must be brought back is something around the long-term viability of an inpatient mental health unit in the Redditch area at Hillcrest with an unsuitable environment. And I make the assumption that something will be coming back along those lines. Is that correct, John, Sarah, Matthew?
Yeah, and just to be clear, obviously GIRF's looking at the approach to the overall pathway for inpatient, so looking at that, but I'm sure the fallout of that will be an assessment of whether our current facilities across the board meet the needs of what we think the future pathway should be. So yeah.
Okay, so on the basis of us seeing more and more sort of strategic issues around Hillcrest, then we can note this report. Are we happy to do that? But as you can see from that, there still remains general concerns around Hillcrest, and I think that's mirrored by everybody from the executives and the non-execs. And we hope that what we see in September will give us a springboard of optimism for the future in the long-term sustainability. Okay, folks, we've had a long morning already, and we've got plenty to go. Can I suggest we take a 5-minute break, refresh our cups, and come back at around 10 past, please? Thank you.